Hello, and welcome to my overview of ACE inhibitors and ARBs. I hope to be able to give a broad overview of these drug classes that can serve as a review or introduction to anyone interested in learning about these medicines, whether to help patients or if you're taking them yourself. So first, very briefly, let's see what I'm actually going to be talking about. Angiotensin-converting enzyme inhibitors, or ACE inhibitors, angiotensin receptor blockers, or ARBs, and kinda aliskiren, or the direct renin blocker. But it's insignificant for the most part. Now these are basically focused on angiotensin II, which is a big deal in the cardiovascular world. We like to keep this hormone low to protect our cardiovascular system. On that note, ACE inhibitors and ARBs treat, or are used to treat, a few things. Blood pressure, obviously, most of you could have already told me that. They are very useful in heart failure, good for the kidneys, long term. We'll talk about that in a bit, and for a couple different types of heart attacks. Now, I've been saying ACE inhibitors and ARBs, but obviously no one just hands these out and says, here's your ARB, so I'll mention some examples, not inclusive of course, for the ACE inhibitors. Lisinopril, benazepril, enalapril, which comes in tablets, liquid, and IV, captopril, etc. Key point here, if you didn't notice, the ACE inhibitors end in pril. Good way to spot one if you don't recognize the name. For the ARBs, losartan, valsartan, olmesartan, etc. None of these are IV, by the way. Again, little common ending here, sartan. Keep an eye out for the ending and you'll be a step ahead. Let's get a little technical and talk about the mechanism of action for these drugs. First, let's talk about angiotensin II, the main concern here. So angiotensin II causes vasoconstriction, tightening of the blood vessels, and increased release of aldosterone, which causes more sodium and water retention. Some of these blood vessels which get constricted are in the sensitive spots of the kidneys, so this can result in narrowing of these already tiny blood vessels, which is not good long term. Also, angiotensin II is involved with remodeling the heart. That is to say, in given circumstances it makes the heart bigger, which might sound good, but believe me, not so much. So angiotensin II is the protein hormone these medicines are concerned with. Now, let's see what they actually do. ACE inhibitors block the enzyme that converts angiotensin I into angiotensin II, hence the name angiotensin converting enzyme inhibitors. Creative, I know, but it gets the point across. So by blocking angiotensin II's formation, we are effectively preventing or decreasing its effects. So the blood vessels expand, you don't retain all that extra fluid, and they protect all those little baby kidney vessels. Also, as an aside, since the enzyme it blocks is similar to another enzyme, it also prevents the breakdown of bradykinin, which then results in further dilation of the vessels and decreasing inflammation. How relevant this is for direct cardiovascular benefit is debatable, but it does contribute to some side effects, so keep that in mind for later. Next are the ARBs. They block angiotensin II from binding to its receptor, effectively preventing it from working instead of just decreasing its existence. Same basic effects, just a different way of doing things. Of note though, they do not affect bradykinin, so that changes some side effect incidence without apparently changing any blood pressure effects. Which is just one of the reasons why ACE inhibitors' effect on bradykinin is debated to not be beneficial to the end result of saving lives. As a brief aside, aliskiren is a direct renin inhibitor, which prevents the formation of angiotensin I, which, yada yada, downstream effect, less angiotensin II formation. You get the drift. Doesn't seem to be as good as ACE inhibitors and ARBs, and you can't take them together because there is no further benefit, just increased side effects, so it's not really commonly used. Now for the side effects. I will focus on the more relevant ones, or the ones that have a greater impact. First of all, hypotension, which basically shows up as dizziness, lightheadedness, something like that. Takes the body a little bit to get used to that lower blood pressure, but once it acclimates, this should go away. However, just like with any blood pressure medicine, orthostatic hypotension, or the lightheadedness from getting up too quickly, is always worse and does not get better. Big fall risk for the elderly, especially if they still have a little pep in their step. Next big one, hyperkalemia, or higher potassium levels. Not typically an issue with an otherwise healthy patient, but that sometimes is not as common as we would like. So keep that in mind, might need the potassium checked for some people. Next one is cough. Now this is more common in ACE inhibitors because of bradykinin, but it can still happen in the ARBs. This could happen any time while someone is on one of these medications, so within a week or even years later. It is a dry cough that sticks around. Just switch to an ARB if it happens, and it should go away. A serious thing that can happen is angioedema. This is very rare, but it can be fatal if not treated. So basically it causes swelling of the lips, throat, tongue, can cause you to stop breathing. Again, this has a slightly higher chance in ACE inhibitors because of bradykinin, but I wouldn't use that as a reason to choose an ARB over an ACE inhibitor. So now, just for some interesting facts to round this up. The first thing is acute kidney injury, or AKI. Now I know what you're thinking. I thought these drugs were renoprotective. How can they cause kidney injury? Now that is the interesting part. So while these drugs have been shown time and time again to help the kidney out, especially in diabetic patients, when someone is first started on these, it actually initially drops the kidney function. So if someone is teetering on the edge or they have other things harming the kidneys, ACE inhibitors and ARBs can actually cause an AKI. Now, how I like to present it is this way. Your kidneys are declining just regularly as you age. 'Tis life. But if you take one of these medications, it drops the kidney function, but then slows down the decline for a long-term benefit. Also, this graph is just meant to drive the point, not to represent the actual effect. Another interesting little aside is that another blood pressure drug, amlodipine, causes swelling. A lot of time, diuretics or water pills are used to treat this, but actually ACE inhibitors or ARBs are how this should be treated, as diuretics will not help swelling caused by amlodipine. This is a very important distinction which commonly gets overlooked. I hope this brief talk on ACE inhibitors and ARBs has been beneficial for you in one way or another. These medications are great for blood pressure and heart failure, so they are very commonly used, and there is a plethora of information on them. So I tried to hit the highlights, and you can certainly dig deeper with a quick Google search. I'll be releasing videos fairly regularly on medications and pharmaceuticals, so if you like quick, concise overviews, I hope you subscribe so you can keep benefiting from my videos. Have a good day.